Welcome to the American Institute of Healthcare Professionals Videogram on the needs of the dying. And this video is in particularly correlated with PT 450. And my name is Mark Moran. I'm covering in for Dr. Dominic Fleury, who is the course author for PT 450. And what we're going to do is discuss the elements of treating the whole person. And when we talk about the whole person, we're speaking about their physical needs, their emotional and mental needs, and then their spiritual needs. So this video will look at those three categories and how important it is. But one of the biggest problems in the healthcare field is usually only the physical needs are met, and many doctors are not trained to have a good, what we would call bedside manner. And this is also true for any healthcare professionals, not just doctors, but nurses and others who help individuals who are terminally ill or who are dying in a hospital setting. They're not equipped, they're not trained enough to be able to compassionately understand the necessities of the whole person who is experiencing death. So when we look at the physical needs, number one, we're looking at their pain management and comfort. And those are two of the biggest things, pain management and comfort. When someone is entering into the final days of their life, it's almost like a patient bill of rights that they receive this type of care so that the pain is minimized to the most it can be and that their comfort is met, as well as the use of potentially, instead of dying in a sterile environment, having hospice care, which can really help an individual die in their own home if they have family there. Also, when we look at emotional and mental needs, we're speaking of addressing the person during death, speaking to the person, not just about the person, not allowing death to be a taboo subject, and seeing death as part of life, not a defeat, and also understanding that those who die in facilities, these facilities are very sterile in regards to what the individual who's dying was used to maybe at home. So it's a very barren environment, and we have to look at the emotional need of the individual and maybe their fears that they're experiencing as they enter into death. And obviously spiritual. Are the individual's religious and spiritual needs being met? Are the proper religious authorities being consulted? So let's take a look at these three categories with a little bit more detail. The first, obviously, is physical care and pain management. And as we stated, the right to die dignified without pain and discomfort. And that's where acute pain and chronic pain treatment comes into play. And that's where various types of pain relief is very much analyzed. So pain treatment that hastens death might not be denied if death is unavoidable. So certain individuals might request a certain type of pain that might take some of their consciousness away or also lead to a quicker death, but it's reducing the pain and giving them more comfort for something that is unavoidable. And this is where we also come across two very important terms: extraordinary measures versus ordinary measures in sustaining life. And the greatest rule of physician is to cause no harm. So when we look at ordinary measures are things that are trial proved, and have a track record of being able to promote a certain result. So at a certain point, well before the death trajectory, certain individuals might take upon ordinary measures to try to save their life or preserve their life. But there may be what we call extraordinary measures. And extraordinary measures are not tested, and some of them might have 50-50 results. Others might prolong life, but not cure life, and they're not necessarily a option that is the least painful. It might cause more pain indeed. So when looking at extraordinary measures, it's usually up to the patient because they're not proven. Ordinary measures, though, are the basics, which everyone is usually giving as a chance to survive and to move forward. So what type of pain treatment is going to be giving and so forth. The other part besides pain is helping keep the individual who's dying comfortable. Breathing issues, eating issues, bed sores, nausea, vomiting, insomnia. These are some of the most common ones that are seen in hospitals. So how can these things be alleviated? How can this individual have more comfort, more stability in their final days, their final hours, and so forth? Other element is hospice, and it's really a blessing to be able to die in your own home or to have a situation where comfort is put ahead over necessarily cure. Now, a lot of individuals are terrified to enter into hospice because they feel like they have given up, and that shouldn't be the mindset. The mindset instead should be more about managing symptoms, finding comfort in your possible last days, but still having that hope, even though it doesn't appear that it's there. But it's, again, seeing death as part of life, not as the end itself, that should be avoided at all costs. If you celebrate birth and celebrate death properly, then you're about experiencing it a certain way in itself. Now, when we again speak of care of the patient, this emotional and mental needs are the ones that are usually the most neglected, especially those in healthcare, due to maybe lack of training in these types of areas. And in many ways, these needs are not met from healthcare, from the family itself, and in a kind of a intergrown weave within society itself of an attitude that sees death as something negative in itself. So in facilities, the first set of notes, in facilities, death is seen as failure for many, and it is not seen as, instead of a good way to die, when a patient dies, it is a failure for the doctor. The doctor was not able to repair. The physician was not able to repair. And that is seen as a failure. And that should not be seen necessarily as a failure if the proper care was given. So physicians in this regard, when that moment comes, need to be able to better articulate the fact that someone is dying. In many ways, some physicians are like mechanics. They know how to fix whatever might need to be fixed, but they really don't understand what maybe the individual is going through. They understood how this organ works, but they don't really understand how the person is feeling because of that organ no longer working. There's an emotional and mental despair that can come with the fact that your body is shutting down. And sometimes physicians have a hard way of wording it, maybe because they feel awkward or have anxiety of their own, or maybe they just were never really trained to speak the language of an individual, and they're so much in medical terminology that they have a hard time translating how they talk with their colleagues, maybe to a patient. So bedside manner is something that is lacking in many cases with healthcare professionals. Within the family and approximate caregivers, death can sometimes also be a taboo subject. Families can grieve the terminally ill as if they're already dead, and they can speak with the physician regarding conversations about them as if they're already gone. So we have the individual, the terminally ill individual, laying in bed, hearing these conversations, these decisions, and it's almost as if they're not there. They're not involved in the process. They're not part of the process. So that's an issue that neglects as well the emotional and mental needs of individuals. And from a society, we breed these types of attitudes and these types of conversations because death is not seen as part of life itself. And everyone wants to ignore death instead of discussing the issue of death with others. So terminally ill and their many emotional needs and mental needs are not met the way they need to be met because of these attitudes about death itself and how death is viewed. And because of this, many families are unable to have discussions with the terminally ill family member that should have been made, that could have been made. Family grudges may not be resolved, or ideas of what a family member wants to give to another family member is never resolved, or discussions of the past, things that want to be shared by the dying individual with their last breaths. These things are avoided because everyone is afraid to discuss and talk about death and to meet the emotional and mental needs of the individual. Finally, as we spoke of, spiritual needs are the third element. And spiritual needs are rarely met by physicians because there is a feeling of a separation between state and church. And so professionals in healthcare usually leave it to the chaplain. And there's a fear to discuss these issues, maybe because they're not adequately trained in it, or maybe they don't wish to offend someone. And bringing up spirituality or religion doesn't necessarily have to be an issue of trying to convert someone, but merely an issue of acknowledging spirituality and asking someone simply, do you have any spiritual needs that need to be met? Or do you have any religious needs that need to be met? Is there a certain chaplain, or do you need a rabbi, an imam, or a priest, or a minister? What needs do you have religiously? And sometimes individuals will be very welcoming to this and very happy that this was brought up. And maybe they do have some needs, or maybe they want some religious objects brought to them from their home so that they can have these objects around them as they face death. Many cultures have very deep religious rituals surrounding death, within Hinduism and Buddhism as well. And these rituals and these religious objects can bring a lot of peace to individuals who are preparing for death. So just like we need to address emotional and mental needs, we also need to address the spiritual needs. And in doing so, healthcare physicians and healthcare professionals can treat the whole person, meeting the dying's physical needs, meeting the dying's emotional and mental needs, and finally meeting the dying's spiritual needs. We offer here at AIHCP a Pastoral Thanatology certification, which is open to qualified professionals. The program is online and independent study. The link below will take you to it. Our phone number is 330-652-7776, and our email is info@aihcp.org. And the resources for this particular video was Care of the Dying Patient, edited by David Fleming and John Hagan III. And again, this video is in correlation with that text for PT 450. My name is Mark Moran, and I was filling in for the course instructor, Dr. Flary, and I'd like to wish you a good day and also happy studying.